Hi, I'm Anthony Gosh, a consultant spinal neurosurgeon and founder of the Spine MDT, and this video is about the treatment of spinal stenosis, specifically lumbar spinal stenosis. Stenosis is a Greek word for narrowing, so it's essentially narrowing of the spinal canal, the channel that all our nerves run through. So here we have the human spine, the front and the back. It consists of a stack of bones with arches. And if we zoom in a little bit here, we see the stack of bones here with the arches at the back, and this here is the tunnel in the middle. And the reason this happens over the years, it usually happens with age, with wear and tear over the years. So a couple of areas in the spine focally get narrowed because of thickening of the ligaments at the back of the spine. These are straps of tissue that hold the two arches, hold the arches together on top of each other. They start to thicken up, form a kind of callus, and buckle a little bit and narrow it. The disc, the cushion between the two bones, can sometimes flatten a bit here and bulge out slightly. And in combination with that, the facet joints, these little joints either side at each level, the bone of those joints starts to thicken up. And all of that together causes a resultant narrowing in these areas and entrapment of the nerves as they run through the spine. We know from MRI studies in patients who do not suffer with any symptoms, who have been used in control groups, that often it's an incidental finding that doesn't cause symptoms. If it causes symptoms, generally the symptoms are pain that radiates down one or both legs, that worsens when you stand or walk for a period of time, and then your walking distance starts to shorten. So the treatment strategies I'm going to talk about today are specifically to treat pain that radiates down the legs and to help you improve your walking distance. Now, if you've been investigated for back pain, but you don't really have the sort of leg pain that I've described, and your MRI scan happens to show stenosis, that doesn't mean that that's the cause of your back pain. It can cause back pain in some scenarios, but there's a very specific pattern, and that's why it's really important to be assessed by an appropriate practitioner for that. A fundamental principle of medicine is to treat the patient and not the scan. So if it is leg pain that you have and your scan does show this, then yes, there are things we can do to help with that, to try and just generate a little bit of space and breathing room around these nerves so they don't give you that pain. Sometimes just the unbuckling of this ligament alone, so stretching it a little bit, can actually alleviate some of that space. So physiotherapy, where you learn exercises to stretch out this ligament, can be helpful. So there are sitting forward flexion of the spine when you're sat in a chair, and a physiotherapist gets you to lean forward and stretch out. As the spine bends forward, these spinous processes here come apart. If you're angulating this way, these come apart, stretching that ligament, therefore flattening it a bit. And that can often help alleviate the pain, because patients often find that when they sit in a chair or lean forward, that alleviates the pain. So sometimes stretching these that little bit further gives you a little bit more leeway. It's not a cure of what's found on your scan per se, but just that little bit of space created for some time can help alleviate the pain. And then there are various further stretches that can be done that also have the same effect. And a good number of patients that do this will end up avoiding surgery. Injections to the spine, such as caudal epidurals, epidural injections where some steroid and local anesthetic is injected into the spinal canal around the nerves, can be helpful, but it's not a measure that you do on its own, because once the steroid gets reabsorbed, eventually the symptoms do recur. So that's something you can use as an adjunct to the physiotherapy I just mentioned, which can just help you do the exercises a bit more effectively. But I personally tend to avoid the injections because I find the effect of it is very short-lived. So if all that has failed, then it may be worth considering some of the surgical options. Come back to this diagram. So the idea of the surgical option is to try and create space around the nerves that's a little bit more permanent and a bit more definitive. So effectively removing this ligament here, the ligamentum flavum we call it, and undercutting these facet joints at the side of the spine that kind of compress the nerves from side to side. And you don't usually have to touch the disc. Usually that alone alleviates the pressure from the nerves. And there are a couple of operations that achieve that. A very old-fashioned operation is called a laminectomy, and that's when the whole of the arch at the back of the spine is removed to do so. And that's done through an incision in the lower back under general anaesthetic. The muscle is moved out of the way, and this whole arch is removed completely with the ligaments top to bottom to create space. Over the years, I've moved towards doing a more minimally invasive procedure where we use a much smaller incision and you don't have to remove the whole of the arch. You just make a small window at the back of the spine. Through that window, under a microscope, just from one side of the midline alone, with the instruments we have and the technology, you can, from that small window under a microscope, remove all of the ligament that's causing the narrowing, also undercut the facets from that window, leaving that midline bit of the arch with the muscle attached to it, leading to a quicker recovery, and hopefully thereafter slightly less likelihood of any instability of the segment. Now, another procedure that's been around for quite some time that I personally don't do and I'm very much against is distraction surgery, or the insertion of a distraction device. One such device is called an X-stop. The idea is you go in through a small incision in the back, and between the two arches of bone, you put this metal sort of wedge there that separates them apart, pushes these two bones apart to flatten out the ligament. And that's kind of been sold as a quick procedure for patients who perhaps have medical comorbidities and want to keep the anaesthetic time short. As a quick operation to try and achieve the same thing. Where there's stenosis at a single level, for me personally, in the same amount of time, I can do the operation previously described, where I decompress, and that's more thorough and definitive. Doesn't leave any hardware in the body, which has its own issues with infection and so forth. And one of the other problems I have with this procedure with the distraction is you're kind of fixing the spine in this position that it just doesn't like. You're pushing this one, you're angulating the segment forwards, which the spine generally doesn't like. Another reason I don't like it is that a big part of my practice is revision surgery. I've seen many patients who've had this device in, it's either failed or hasn't worked, and I've had to go in and remove it and complete the operation more definitively. Now, surgical practices vary, and in many countries, specifically the United States, there's a bit of a low threshold to fuse these segments. So they decompress this area and then they feel a necessity to fuse the segment, i.e. remove this disc completely, place a cage in that area, which is a type of breeze block, and then fix it together with some screws, which is quite a big undertaking relative to just a simple decompression. And the reason they do that is, in some instances, to try and restore what they call sagittal alignment, this natural curvature of the spine. Often in patients with stenosis, you start to lose that and there's a bit of a forward curvature. This excellent study that was published in the Spine Journal looked at patients undergoing a simple decompression, the operation that I described that I do, without instrumentation, without any hardware in the body, look in patients with stenosis, and looked at their sagittal imbalance and found that the sagittal imbalance, the alignment, actually improved with just a simple decompression alone. In the context of stenosis, I only carry out a fusion if the stenosis, the narrowing, is caused by a spondylolisthesis. That's where one bone has physically slipped forward relative to another bone, and therefore that has caused the narrowing. So in this case, fusing the segment, putting the cage in I described earlier, with the screws and the constructs, and pulling the bone back into realignment actually widens the space in the spinal canal. I hope you found this video helpful. If you did, I'd be very grateful if you can click like and subscribe. It really helps people suffering with back pain and spine disease find information that I try and post weekly. If you've listened to this on a podcast, I'll be very grateful for a 5-star review on whichever platform you listen to this on. Visit us at spinemdt.com for more information and to see how we can help you. Thank you.